Hi everybody. This is a set of slides that I need to get done, and this will finish all anatomy, and we'll be able to start on a clean slate with all the rest of it later on. So this material will be on test number 2. It's not a large set of slides. It's just the muscles of the abdomen, and then, as I said, we'll be finished anatomy. So as it says, muscles of the abdomen. So what I want you to think about when you look at the muscles of the abdomen is this Union Jack you see down in the corner. And the muscles actually lay out like this in regards to their anatomical position. So we have a set of muscles that go straight up and down from sternum to pelvis. We have a muscle that transversely goes across all the way around on a transverse plane. And then we have these oblique muscles coming from up above and down below. So whenever you're doing this, just think of that Union Jack and it will help. So there are 5 abdominal muscles within the wall, and as I said, they form the Union Jack. There are 3 flat muscles, and these are the external oblique, the internal oblique, and the transverse abdominal. And then there are 2 vertical muscles, which are the rectus abdominis, and possibly one you haven't heard before is pyramidalis. So you can see here in the diagram, that sort of that 6-pack that everybody aspires to, which is ridiculous for most of us. But you can see that they do lay out. And when I talk about the vertical muscles, I'm talking about the ones either side here. So all 3 flat muscles attach anteriorly to a strong, large aponeurosis. So within that wall of the stomach, we have this flat aponeurosis, which you think of again as a sheet of tissue. And then it attaches at the midline to something that runs right down the middle, right through your belly button. Think of again from your rib cage, your xiphoid process, all the way down to your pubic bone. And this line is white and it runs as a straight line. So therefore it is called the linea alba, which means white line. And the abdominal muscles all sort of attach and meet through this aponeurosis along this linea alba. So this is why we say all the flat muscles attach to this large aponeurosis, which then attaches to the linea alba. Now, this linea alba, along with these aponeuroses, because we have to think about, we've got a right side and a left side, they all come together. They form what is known as the rectus sheath. Now, the rectus sheath is tendinous tissue that is, as I said, coming from the edges of the muscles in the anterior abdominal wall and then attaching onto this linea alba. Within this rectus sheath, we find the 2 vertical muscles. So, when we look here in the diagram, we can see here again, we can look here first in the photograph. We can see here, we've got the 2 vertical here, and then we have right down the middle where the umbilicus is. This is where the linea alba is, running straight down through the middle. And these vertical muscles here, both the right and left rectus group, they actually sit within a aponeurotic sheet of tendinous material. So we can see here in the diagram, here are our 3 flat muscles here, our external oblique, our internal oblique, and our transversus abdominis. So this is our 3 flat muscles. And we can see here where they just kind of end here. And then we can see this aponeurosis kind of coming out from them and then heading into the center here, the linea alba. So again, all 3 flat muscles have this tendinous aponeurosis that heads from the tip here, again this would be anteriorly, all the way to the linea alba here, which is running down the middle. And the 3 flat sheets and their aponeuroses coming into the linea alba surround the vertical group, the rectus group. So the 6-pack that you think about actually sits within a rectus sheath of tendinous tissue, both on either side, anteriorly and posteriorly. So it's completely surrounded by this fascial sheet or this tendinous sheet, this aponeurosis, known as the rectus sheath. We can see it here as well in this diagram. So we can see here that here's our transversus, our external oblique, and our internal oblique. And we can see how they all come into this large aponeurosis. You're seeing here kind of cut away below, but it's here. We can see it here as well with the transversus group. We can see it here with the internal oblique group and then the external oblique group. all coming to attach to this linea alba, which is running right down the middle. And you can see how the rectus group, the vertical group here running up and down, is surrounded by this rectus sheath both posteriorly and anteriorly. And the reason you're seeing the muscles here is because the artist, of course, has cut away the anterior portions of this rectus sheath to expose the rectus group underneath. Okay, so again, if we go back to this diagram here, we can see here again are our 3 flat sheets forming this aponeurosis that completely surrounds the vertical group with this linea alba in the middle. So to further explain this rectus sheath, we can say that it is an incomplete fibrous compartment, and it is formed by the decussation. Now, decussation means crossing. That's all it means, is that this crisscrossing and interweaving of the aponeuroses of the flat abdominal muscles. So there, we've got these 3 layers here. We can see here's our external oblique, internal oblique, and your transverse. You can see here on the tips we have this aponeurosis here, this tendinous sheath that comes together, crisscrosses back and forth, and forms this complete compartment that the rectus group sits in. So there are 3 layers to it. The first is the anterior layer, and this is an interlaced aponeurosis of both the external oblique and the anterior lamina of the internal oblique aponeurosis. We have the posterior layer, so anterior meaning it lies anterior to the rectus group. We then have a posterior layer which lies posterior to the rectus group or the vertical muscles, and this is fused posterior lamina of the internal oblique aponeurosis and the transverse abdominal aponeurosis. And then we have something called the crescentic line or the arcuate line, and this is a border or demarcation between the superior 3/4 of the posterior wall of the sheath and the inferior 1/4. Don't worry too much about that arcuate line or that crescentic line. That's not too important for us. Obviously, for a surgeon who's going in, it would make a big difference, but for our purposes, we just need to understand where it is. So we can see here where here's our transverse here, and we can see that it is providing part of the posterior rectus sheath. Here we can see the external oblique here, and it forms the anterior part. And then the internal oblique here we can see provides aponeurosis both to the anterior portion and the posterior portion, thus forming this entire sheath. And please remember, we have one on the right and one on the left, and they both meet right in the center here at the linea alba. So again, forming this crisscrossing compartment that the rectus group sits in. You can see it here a bit as well, and you can see how the rectus group is sitting within the sheath here, and it's been kind of cut away a bit. So let's do the muscles themselves. So the first is the external oblique, and these are one of the flat muscles. So we'll do the flat muscles first before we do the vertical ones. So the external oblique arises from the anterior iliac crest, the pubic crest and tubercle of the pubic bone, and the abdominal aponeurosis. And it goes to the inferior borders of ribs 5 through 12. So we can see here is the external oblique here. So we can see this fascial sheet, this aponeurotic sheet here, kind of from the lateral aspect. And we can see how this forms the attachment of this muscle and then heads up to this external surfaces of the ribs 5 through 12. So anterior iliac crest here. We've got the pubic crest down here at the pubic bone and the tubercle of the pubic bone, so both down here, and the abdominal aponeurosis, which is this big thick sheet here, and then coming up to these lateral aspects of the ribs. So you can sort of see in the other drawing here, here's your external oblique here. So it's heading basically from inferior to superior, obliquely heading from medial to lateral. Superiorly inferior to superior, and obliquely heading from medial to lateral. So we can see here's the linea alba here, drawn in here, and of course the fascial sheet compartment in this drawing is covering the rectus group. So you can't see the muscles underneath, but you can make them out. And you can see how it attaches here on the external oblique. Again, medial to lateral, obliquely inferior to superior. Its functions, it helps when working bilaterally, it flexes the trunk of the spinal joints. When unilaterally, it ipsilaterally flexes the trunk of the spinal joints. It is a contralateral rotator of the trunk of the spinal joints. Like all the flat muscles, it does compress the abdominal pelvic cavity. And because it reaches up to the ribs, this pulls the ribs down. So in other words, it depresses them. When those are all fixed, when this muscle contracts, it causes posterior tilt of the pelvis at the lumbosacral joint and flexes the lower trunk relative to the upper. Its innervation is the intercostal nerves on the ventral rami of T7 to T12. So again, medial to lateral, inferior to superior. Now, if we look at the internal obliques, this arises from the lateral 2/3 of the inguinal ligament. Remember the inguinal ligament running across from the AIIS to the pubic bone, the iliac crest, and the thoracolumbar fascia. So this muscle goes all the way around to the back to the thoracolumbar fascia, along, of course, with the erectors, which we've already taken. So the lateral 2/3 of the inguinal ligament, the iliac crest, and the thoracolumbar fascia, and it goes to the lower 3 ribs and the abdominal aponeurosis. So here is our internal oblique here, and you see that this is going from lateral to medial, whereas externals were from medial to lateral. Again, inferior to superior, but it's on the lower ribs here, and we can see it again, it's going from lateral to medial. Here's your external oblique, medial to lateral, and superiorly. Here's your internal oblique here, right? A lot of aponeurotic material here, tissue here, holding this all in, going from iliac crest upwards from lateral to medial into these lower ribs here. So functions, it flexes the trunk of the spinal joints when working bilaterally, just like the external oblique. It ipsilaterally flexes the trunk of the spinal joints unilaterally, and it's an ipsilateral rotator. So the external obliques are a contralateral rotator because you're going from this lateral to medial, and of course the internal obliques because they're going from from medial to lateral, from lateral to medial, then you're getting ipsilateral rotation. It too compresses the abdominal pelvic cavity, the same as the external oblique, and it depresses the rib cage as well. And this is the intercostal nerves, ventral rami of T7 to L1. So for stretching it, you can see there are a lot of variations to isolate these. Kind of rare to really isolate them entirely, but you are working both external and internal obliques in any of these positions. We can see at the top here, this is the the passive assisted by the therapist on the table. And of course, you can see actively when the patient does it. In these muscles, trigger points tend to produce pain in the chest, especially the superior trigger points up near the ribs, abdomen, pelvis, and groin, which is then the inferior. So up into the chest with the upper trigger points, down more into the groin with the lower trigger points. This can also cause visceral symptoms such as heartburn, indigestion, abdominal cramping, and nausea. So we'll give the impression of that. Next, as the last flat one, because there's 3 flats, we've already done external, internal. This is the transverse abdominis, and this is telling you that this runs right along that transverse plane. Its attachments are the lateral 2/3 of the inguinal ligament, the costal cartilages of ribs 7 through 12, the iliac crest, and thoracolumbar fascia. So this too wraps all the way around and goes to the linea alba of the abdominal aponeurosis. So you can see it runs straight across in a transverse position, right, all the way back here posteriorly, that thoracolumbar fascia, iliac crest, and so forth. Again, inguinal ligament around the front, so here a little bit in the front, the inguinal ligament as well, and then to the linea alba of the abdominal aponeurosis. So again, coming around from the posterior aspect, running along the transverse plane to attach anteriorly. This is a lovely diagram here because you can see they've removed part of the rectus sheath so that you can see the inside here of the vertical rectus abdominis. So transverse running from all the way back here, all the way around anteriorly to the front. Its functions basically is to compress the abdominal pelvic cavity. Innervation is intercostal nerves, ventral rami, T7 to L1. The stretch is the same as it is with the 2 external and internal obliques. The one thing I want to briefly discuss before I get to the vertical group is we always thought for a long period of time that the vertical group were the set of muscles that we absolutely had to train when people had back pain and so forth. All of you now know, and you hear this all the time, about core strength. When we're discussing core strengthening, it is these 3 flat muscles that we are strengthening. And what's lovely about them, if you look at them all together and think about their attachment, they completely wrap around your midsection from posteriorly at the thoracolumbar fascia all the way around anteriorly to the linea alba. So 2 angles between external and internal obliques, and of course transverse all the way across. This is why it's vitally important to have these 3 flat muscles as strong as possible through this core work, because it very much supports and stabilizes this spinal area and helps with preventing low back pain. So when we're approaching care and remedial exercises for people with low back problems, it's with all three of these muscles. So we can see here in the diagrams, back here, you can see how they all wrap around. So here's our external oblique, here's our internal oblique. Again, external is of course more superficial, internal deep to it, and then the deepest of the three is the transversus. So between oblique this way, and straight across transverse wise, you can see how it is a lovely stabilizer for this whole abdominal area, and therefore takes a lot of pressure on the back, off the back, sorry, and this is what you're working when you're working with your core. The transverse group has a little bit of a different pattern with trigger points, so it produces pain along that costal margin, broadly throughout the abdominal region, deep to the internal and external obliques. It's really quite difficult to separate this trigger point more from the patterning than it would be from actually isolating it out. The next are the two vertical muscles. The first one, of course, is rectus abdominis, which everyone is very familiar with because this is your six-pack. And it arises from the pubic symphysis and the pubic crest and goes to the xiphoid process and costal cartilages of ribs 5 to 7. It flexes the trunk of the spinal joints when both working bilaterally. It laterally flexes the trunk of the spinal joints when working unilaterally. Of course, like the others, it does compress the abdominal pelvic region, and it does help depress the rib cage. When we have reverse motor actions here, when we're stabilizing the upper trunk and ribs, reversely, it posteriorly tilts the pelvis at the lumbosacral joint and flexes the lower trunk relative to the upper trunk. So this is, when I talk about working the abdominals, not the hip flexors when you're on some of these machines. Innervation is the intercostal nerves, the ventral rami of T5 to T12. So we can see it running vertically all the way up here. There are small little parts of it. You can see there little squares, a little bit longer inferiorly, a little bit longer superiorly into those intercostal areas and these costal cartilages. And then we can see how they're sort of packaged within that rectus sheath. Remember, we've got the rectus sheath here. You can see it in the drawing here behind the rectus group, but they have removed it anteriorly, so you can see the muscles here as well. And this is lovely. You can see it sort of all laid out here in the diagram, how they all relate to each other, and you can see how they just really do help support and work this whole midsection area of the person. To stretch the rectus group is literally extension. There's a movement for this for yoga. I can't remember what it is, something cat or whatever. So therapist doing it, or the client doing it themselves actively. Trigger points here can produce pain felt over the lower aspect of the heart, diffuse abdominal discomfort, and visceral symptoms again, such as heartburn, indigestion, abdominal cramping, nausea, and even diarrhea or vomiting. So this one can cause diarrhea or vomiting as well. The last one is a muscle that's absent in about 20% of people, so but it does have its own referral pattern, so sometimes it can be a cause for discomfort and no one can find the problem until you get in, because you know from Brian about trigger points. So it is a small triangular muscle. As I said, it's absent in about 20% of people, and it is anterior to the inferior part of the rectus abdominis. It attaches from the linea alba to the anterior surface of the pubis and the anterior pubic ligament. So because of its name, pyramidalis, it's pyramidally shaped, like a triangle. Basically, it's thought to play a role in tensing the linea alba to help stabilize all these muscles as they find their attachment on the linea alba. Innervation is T12 to L2. There is no stretch or strengthen for it, but you can see it here at the very bottom, anterior to the rectus group here, just a small pyramidal muscle, and you can see it here in the cadaver as well, sort of setting it up. Trigger points here travel the pubic crest upwards towards the navel, so sort of a unique kind of trigger point up towards the umbilicus. Muscle testing you'll find in the book. I'm sure you've done them with lab, or you shortly will be. The last muscle is kind of a back muscle, but because it sits in the posterior aspect of the abdomen, we consider it a posterior abdominal muscle. Its name tells you kind of what it is, quadratus lumborum. It is a large square muscle in the lumbar region, hence its name. It is better palpated from the posterolateral position or posteriorly. You really can't get at this muscle anteriorly. It's It's far too deep. It lies behind all the viscera, so you have to kind of do it from the back. This is a nasty little muscle. It causes lots of problems in people. It has lots of trigger points, and you'll find you'll be working it quite a bit when you are treating patients with low back pain. So we can see it in here, this large kind of square muscle here, and you can see where it sits way back in the back of the abdomen. So here's your spinal column here. We've got psoas and iliacus here, which we'll be talking about next semester. Here's some of the viscera, but you can see this is very, very deep in the abdominal cavity. And again, better approach posteriorly or posterolaterally. We can see it here as well, fitting in. So attachments. Medial 1/2 of the inferior border of the 12th rib and transverse processes of L1 to L4, and it goes to the posterior medial iliac crest and the iliolumbar ligament. Remember, that's the ligament that goes from the tip of the TVP, usually of L4, sometimes L5, to the iliac crest. Its functions: it elevates the ipsilateral pelvis at the lumbosacral joint and laterally flexes the lower lumbar spine relative to the upper spine when it's working unilaterally. It also anterior tilts the pelvis at the lumbosacral joint, extends the lower lumbar spine relative to the upper lumbar spine as well, working bilaterally. Its reverse motor actions. It can laterally flex the trunk at the spinal joints, so in other words, bringing the rib cage down towards the pelvis. It is a depressor of the 12th rib, so it's considered a muscle of inspiration, so a secondary muscle of inspiration by pulling that 12th rib down, and it extends the trunk at the spinal joints. So the thing to remember here, it pretty much attaches almost to every lumbar vertebra in the low spine. Its innervation: lumbar plexus T12, L1, L2, and L3. So we can see here, this is the lumbar plexus, so this is sort of where it's coming from when we say here T12, L1, 2, and 3. So here's L1, 2, and 3 kind of coming together to work with it. So as I said, you can see the lumbar plexus here in innervation. Stretching it is side bending here because it is a ipsilateral lateral flexor, so going into contralateral lateral flexion will help with this. You'll also strengthen this with this side plank. It works with all the other muscles in the core, and it'll work in the side plank. And this is therapist stretching as well. Trigger points in QLs can produce low back ache, usually felt deeply, occasionally sharp stabs of pain. Patient can have difficulty turning in bed. Strong pain when coughing or sneezing. It can result in decreased spinal flexion and contralateral lateral flexion and ipsilateral elevated pelvis. Referral can also involve the buttocks and even the groin, even into the scrotum in males. The way I always like to remember it was 4 points on the QL, 4 points generally speaking on the gluteal regions. Again, with this occasional referral into the genitalia area, and males can express that they have pain in the scrotum. So that's it. You will need to know this for the test on Thursday. Thanks for listening. I will be sending out a big announcement. I will not be in class today because I've got a medical situation going on. So please make sure that you do go through this set of slides for the test this week. Thanks again.